So thank you to the previous panel for the dive into the provider perspective. And let's start with a few thank yous for Cambia Grove for hosting this, for Jessica and Nick for keeping the wheels on the bus, and Maura and the rest of the team for helping keep the doors open, I think, and get us all here. Thanks to everyone for being here. Appreciate that. Hopefully we've got a good representation of the different stakeholders here. You know, I sit into the manufacturing side, so I don't understand how I fit into all of the 5 points quite yet, but that's part of why I've been showing up for the last few years. And then thank you to the panel for being here. So, yeah, very briefly about myself, so that we can get this out of the way. I'm a designer by training. I have an MBA. I've worked in medical device design and development for the last 18 years, and I run a company now that's supporting care improvements through device instrumentation and unintended variants in care reduction. So that's enough about me. What I'm going to do for the rest of the panel is I'm going to put two things together for you. I'm going to say, would you mind introducing yourself? And then would you mind just giving a brief overview of how you see your role as a payer? Doug, would you kick us off, please?
Hi, I'm Doug Bose. I'm the CEO of United Healthcare here in Washington for our line of business, which is our Medicaid business. And we manage about 210, or actually 240 now, 1,000 members across the state. And we also have Medicare and commercial business as well. I started my career as a therapist. I did that for 10 years and worked in a variety of inpatient and outpatient settings. And you know, the psychiatric care was considered kind of a black box back when I did that. I'm sorry to say it was a long time ago. And I ended up in managed care, one of the first companies that managed psychiatric care. And you know, that's where my career led, and I kept working my way through different companies, and I've seen a tremendous amount of change, particularly in that area. I mean, I think as a payer, we have you know, responsibilities around the quadruple aim, which somebody talked to earlier, pushing quality, making sure things are cost effective, partnering with providers, helping members really understand their benefit and get the most out of the benefit that they possibly can. And you know, we'll probably talk more about that as we go through and how that works.
Great, Doug. So I'm Nathan Johnson. I have the privilege of serving as the Vice President of Strategy and Innovation at Premera Blue Cross. Have been in that role for about 2.5 years. And I've got to hand it to Cambia Grove on one thing. I am such a huge fan of alliteration. So this 5-piece thing has me going from the beginning before I even knew what it was. I was really happy to participate in one of the first rounds on the payer panel, and glad to be back in this kind of more holistic affair today. I also found myself on the 5P journey. My career started in policy with the legislature, staffing healthcare and human services committees. Moved on to the state's largest purchaser with the Healthcare Authority. Several Healthcare Authority alums are in the audience today. I won't try to acknowledge all of you, but you know who you are. Today I find myself with a payer that's already been defined for us, and I'll say a bit more about that role. And this payer that I work for is also now getting into the care delivery space, so I expect that will come up over the course of today's discussion. And of course, as that patient panel noted, we are all patients, and that's my most visceral connection to today's discussion. In terms of the role of Premera or the role of payers in general, I think it's pretty simple and straightforward. We have to know customers. We have to know their interests and needs and level of preference at a much deeper and richer level than we do today. And we're starting from a pretty good baseline with the data we have, but our use of it is fairly limited, so we have to grow up a lot in that space. The second thing we have to do well is know healthcare. Someone's got to know healthcare, and I don't expect all of us in this room are ever going to know it at the depth that a payer is able to know it. Serving up those insights, making them meaningful for the patient is incredibly important. Then we have to connect the two, and there's choices to be made in how we do that, but I see that as bridging that depth of insight for customer preference, needs, desires, with the insights and knowledge we have for healthcare, and serving as an effective bridge between the two. That's our role, and we'll say more of that this morning.
Thanks, Nathan. Hi, I'm Laura Lee, and I actually work for Molina Healthcare of Washington, which is another one of the Medicaid managed care organizations here in the state. And as Medicaid managed care organizations, we're covering over 1.5 million individuals here in Washington, low-income individuals that are covered by Medicaid. Appreciate the alliteration of the 5 Ps as well, but when Dr. Crittenden and Jack reached out to me from Cambia Grove, my first reaction is, I'm not sure this is the right panel for me, because we don't really see ourselves as a payer, we see ourselves as a managed care organization. And it's really a distinction in the sense that it's important to us not to be seen as just someone who's paying the bills. We do so much more than that, and we have a commitment and a responsibility to do so much more than that, especially for the low-income individuals that we serve. So it's about providing care management, and I think Dr. Meek spoke one of the issues in the system about making sure that people are getting the right care, the right place, right time. So care management is critical to that. Also making sure that we're delivering quality and trying to help folks with health promotion. Obviously, we have a whole lot of opportunity, and I know we'll get into some of that as we continue to dialogue. But again, just seeing it as more than just paying the bills.
Hi, I'm Christy Putnam. I'm the Vice President for Provider Partnership Innovation at Cambia Health Solutions and Regents Health Plans. And I have been in healthcare my entire career. I have actually spent most of the time on the provider side. So in my remarks, you're going to hear me talk a lot about the provider. In my journey, I started out on the provider side in strategy, which means how do you fill more beds? How do you get more people in the hospital? And over the course of my career, came to the realization for myself that I want to be working on how do we make a business model that's viable of keeping people healthy and out of the hospital. And obviously, it's critically important that we have hospitals and that entire delivery system when that's needed. But how do we get upstream and provide those preventative services and care that's necessary, addressing social determinants of health early on in the process? And creating a better health system as a result, getting to that quadruple aim. So that's my passion and why I'm here. From what is the role of a payer, I think about it in 2 regards. And thinking about our patient panel from this morning, I'm thrilled that we started there. That's central to this conversation. Is you heard so many concerns and challenges of how we navigate what we've created is to be a very complex delivery system and healthcare system. Our role as a payer is figuring out how to make that easier. And we're investing a ton at Cambia in doing that. And I'm excited to share some of those things with you today. Connecting all the pieces and helping the consumer, the patient on their journey to getting the right care at the right time, understanding their financials, helping to pay bills, and really being that resource. From a provider's perspective, our role is it's the provider that's caring for our members. Our job is to enable the provider to do what they need to do in a way that we're avoiding burnout, getting the right care at the right time, helping to get our data in the hands of the decision makers that you can deliver the care that's needed.
Thanks, Christy. So as you get a sense, we've got a range of perspectives here, and it's not just the payer's perspective. You know, there's essentially the 5 points sitting on this panel with the different people that are here. So going back to the provider's question, what changes in the healthcare workforce and technologies are payers prioritizing, and how are they preparing? Who would like to start with that one?
I'm
Christy?
happy to start.
Yeah, I was hoping you'd start there.
Yeah.
Great.
I see 3 areas in here. The first really gets to, as I was talking about with what patients are looking for. The first is we're making a huge investment from a workforce perspective in care guides. People that are available to a patient that you can pick up the phone and have a care guide, and they will answer any question that you have. What are my benefits? What provider should I be seeing? My mother, I'm her caregiver, how do I help her? I just got this bill and I don't understand it. Whatever that need is, that's what our care guides are there for. And it's through this new product that we have, our new company called Journey, and we're really excited to be launching it and rolling that out. And as I was listening to the patient's panel talk this morning, I was like, this is the solution we have, and I'm excited to that we're rolling out a lot of these solutions. It's still a work in progress, a lot of development underway. Coupled with, so the first is care guides, coupled with AI data science developers, because that has to go hand in hand with that personal touch through the care guide concept, as well as the deep data analytics and software developers that are going to help put this into usable formats so that a consumer can decide, I want to access resources through an app or a website versus I just want to pick up the phone and talk to someone, and different people have different needs. The final piece I would mention is behavioral health. There's such a huge need in behavioral health. We're making big investments to increase access for our members, but it's not enough, and we need more people going into this. We need to figure out better ways to reimburse for it. So I would say the third workforce change would be around behavioral health.
And I think I would just piggyback on that, because especially as a Medicaid focused organization, I think behavioral health is a critical shortage that we see statewide. And so one of the things that we're really trying to support here in Washington is helping with the transformation of the delivery system and really encouraging the integration of physical and behavioral health. So really having a much higher capability of providing behavioral health screening in physical health care, but also having the ability to have physical health care in the behavioral health settings as well. So really expanding that behavioral health capacity, just a critical piece. Another would be expanding telehealth options. We do cover the entire state of Washington, and there are definitely pockets in rural areas where we don't have access, in addition to behavioral health, to other needed specialties and services, so relying on teleconsultation or even telebehavioral health. And a new innovation that we're excited that we're starting to expand now is medication-assisted treatment, or telemat, so basically treating opioid use disorder virtually as well. So just a lot of opportunity.
I'll add a couple of things around technology. And I think I heard a doctor in the audience earlier today who said we don't know who our most critical patients are or what's happening with them. How would we find that out, and how do we know? We do have various pieces of information across different organizations. So as a payer, we have all the claims information. We know who's taking their medication, who's not, who's filled their prescriptions, who hasn't. We know who's hitting the emergency room 30, 40, 50 times a year or more, particularly on the Medicaid side. Providers have an electronic medical record. And we also have other information that we're collecting, particularly in our commercial patients, but even moving into Medicaid members around wearables and things that they, if you've got a Fitbit or something along those lines, but a variety of different things that also provide information. So on a technological basis, we're looking to provide that information and marrying all those pieces of information together, and passing that information in a portable way out to the member so they can take that with them to their provider, but also providing it to the providers that are out in the community. The other thing that we've really been doing for a long time is using algorithms to surface those members that we think are at most risk. And we work with our provider groups. We are developing value-based contracts where the provider shares with us in that work around the savings and improving the cost of care, but also the quality of care. And we're able to surface those members that look like they are the most vulnerable and most likely to have increase in their cost of care and a sort of a negative outcome in their health care. So those are just a couple of places. And I heard someone earlier say that they hate NPS, which is a Net Promoter Score. Does everybody know what Net Promoter Score is? So yeah, so we have been very focused on Net Promoter Score, and we've improved it tremendously for the members around some of these pieces of information that we're providing to the member, which includes things like a health line, like a health coach, and we have a nurse line you can call in 24 hours a day. So there are a variety of ways that we are using technology to help. Now, does that help with workforce? Maybe it helps with the providers if they have more information at their fingertips. Certainly in the large groups we work with, we're providing them a tremendous amount of information so they can work not only on a global basis, but on an individual basis back with an individual member.
I'll just add briefly, a key area we're focused on is interoperability. I know there was an entire summit on that, so I'm not going to try to unpack it. But with CMS rules finally looming, and with technology enablement being what it is, and I would underscore billions and billions of dollars of investment in really excellent siloed data systems, the promise of interoperability and what it could do to the business is something Premera is really keying into and testing with a number of providers, including some represented in this room today, to see what we can drive in the way of better customer value through those things. The second thing I would underscore is a theme already shared by everyone, which is access. Access is a conundrum because it's limited. There's limited supply. We see virtual care as an incredible opportunity and are deeply invested in that, but it alone will not do the trick. So in the community of Spokane, we've undertaken something very different for us, which is direct investment in new primary care capacity, and we're 30 days into that strategy, and are so far seeing the type of demand we knew was there. Premera members are no longer waiting 6 to 9 months for a primary care visit, and that's very satisfying, but there's a lot more to come in that area for us.
Excellent. Thanks, folks. So moving on to our next question. Well, I should say questions. Thanks. The pressing needs you're focusing on. So which are the pressing needs you're focusing on? What are the problems that are driving those pressing needs? And then how do you evaluate the programs that you're actually deploying?
Maybe I'll start with this one. There's many pressing needs. I think the patient panel well established that at the beginning of the day. I think we'll hear a tremendous amount more about that. But customer sentiment and demand is changing, and the healthcare ecosystem isn't keeping up. I think that's a fundamental issue. And it's not just point-to-point solutions that are going to get us caught up. It's something much deeper, much more systemic than that. So the burning platform I see is threefold. First, it's behavioral, meaning that, and it's already been said so many times, I'll just underscore it, we actually have to develop empathy both in our processes, in our humanity, and in our technology to better understand those customer preferences and needs and then administer to them. The second thing is trust. So much of the friction as a matter of burning platform in the system today is a result of distrust and mistrust between all the actors that are represented today. It's not technology that solves that. It's deep, deep leadership investment, and it takes a tremendous amount of time. I think we're on that journey in Washington State and maybe leading the pack in some respects through other, in terms of the country. And the third is something that's easier to talk about because investment is involved, but it's infrastructure. But I think we've seen over the last decade that investment alone, as in the case of electronic health records, does not get the job done. Activating it, using it, redesigning our processes around that infrastructure is even more critical. And so that's a burning platform that I see developing both behavioral, business process, and infrastructure. And we're trying to focus really on all three of those these days.
Okay. Well, I think for Melina, one of the key changes for us has been a change in the population. The individuals that we are actually serving are very different today than they were 10 years ago. 10 years ago in Medicaid here in Washington, we were serving predominantly moms and kids. And today, with the Affordable Care Act, Medicaid expansion, and here in Washington, the integration of behavioral health in with physical health, that population, and age blind and disabled coming into Medicaid, the population, the people that we're working with have a much higher disease burden, much higher behavioral health burden. And so the burning need, I think, for us has been in recognizing that as not only if trying to find, like Doug said, trying to find through data who individuals may be, but then being able to find them and engage with them and help engage them in their own health. And so for us, a big shift has been towards community-based staffing and community-based partnerships. So probably 10 years ago, almost all of our staff, it was centralized, and we were trying to reach out and engage individuals telephonically. Today, half of our workforce is actually out in the communities that we serve. They're community-based, and that alone is not enough. We're also partnering with community agencies and community-based organizations, and we still struggle. It's still a pain point to truly find and engage our population, low-income Medicaid individuals who have a whole lot of other things on their mind that they need to be able to take care of above and beyond their health. So some of the ways that we've tried to address that, again, is through these community and clinical partnerships. and trying to be in the community ourselves much more so than trying to work from the ivory towers.
Yeah, I'll add maybe, we're doing all the things that Laurel talked about, and I'll add one more thing, which I know Melina's working on as well. You know, the state set a goal for us, and actually my friend Nathan here was part of that. Set a goal for us about 4 years ago that we would have 90% of our membership in some kind of value-based contract with a provider, and that the care would be delivered that way. You know, value-based contract really means that the provider participates in the cost and the quality piece and is rewarded accordingly. And you know, I'd never thought we'd come even close, but we're close to 90% now, which is fantastic. It really is a different relationship with the providers. We still have a ways to go. With integration of behavioral health, I think that's changed some of what's happening. But I think that conversation and that push, which also came from CMS, has made a huge difference in the conversation that we are having with providers in the community. And thank you. Maybe not so much. I'm not sure.
Building on some of those themes, as I said, I'm going to share kind of the perspective of how we work with providers, and we've done a lot. We have so much more to do. The areas that I really think we have a burning platform is how do we make it easier for providers to do their jobs in a way that doesn't lead to this incredible amount of burnout that they face. We also are doing a lot in the value-based payment arrangement space. We aren't going far enough, and I don't want to offend any of my friends in the room that are actuaries, because you guys know that I love you, but I believe that we have to get to a place with our value-based arrangements where it doesn't require an actuary to know what you have to do to drive to the result. So we're spending, we have a think tank that's working through how do we simplify this so that you know exactly what you need to do in order to drive to that outcome that's going to get that payment, which is the whole point of a value-based arrangement in the first place, is how do we reward you for delivering on the quadruple aim: quality, cost, and experience for the member. And rather than we give you this data that you have to weed your way through, and at the end of an 18-month period, maybe you get paid because of something that you did, or maybe it was random chance that you know exactly what we're looking for to drive to. And so I think that as health plans, we owe you more innovation in that space, and that's something that we're working on. So I'm excited to see where that goes. The other piece is we are sitting on a wealth of data, and I'm excited about what we're doing in the space of interoperability, as Nate talked about. We're one of the founding members of the Da Vinci Project, which is not the robot. It's a national consortium of payers and providers and the EMR vendors, getting together to figure out how we take use cases and put them into practical applications so that we're sharing data in real time that's going to empower the ability to drive value-based care. We're working on a couple. One of them is 30-day medication reconciliation, where all the evidence points to if you can if the primary care provider can review the medications after a discharge within 30 days and make sure that the dosing is right and the patient understands what they're supposed to be taking and there's not duplications or conflicts, that it can reduce error and harm. But oftentimes the providers don't have the right information or know that their patient's even been in the hospital in the first place. So through interoperability, we're working on setting up systems that information is being transferred and getting ready to test the results of that first proof of concept that we can plug and play with other providers and other health plans as well. So we're doing a lot in this space, and I think it's really going to be transformational. But it's a long journey, but we're on that right path.
So, Christy, how do you actually evaluate what you're doing? How do you determine whether or not it's having an impact?
Yeah, absolutely. And so at the end of the day, the results that we're driving to is experience for the member. And I know that some people don't like NPS, but our NPS scores are 65 to 68, compared with averages in health plans of about 28 for members that are in a value-based payment arrangement with us. So definitely demonstrating that there's value in that to the member. Obviously, we look at costs. How well are we doing at driving down costs, and we're able to demonstrate that we're seeing improvements in members that are participating in these arrangements compared to those that are not. And then obviously quality, wanting to make sure that care gaps, evidence-based, things that should happen if a member has diabetes or turns 50 and needs a colonoscopy, right? Those things are happening. And demonstrating that we have 20% better results for members that are in our value-based arrangements than those that don't. So really centering our outcomes on that triple aim measures.
Awesome. Doug, I'm going to pick on you with this one as well. How do you evaluate the programs that you support?
Yeah, it's similar things. We do look at NPS not just for members but also for providers. And NPS scores vary. Our Medicare product, the NPS score is very high in the 70s. Medicaid is lower in the 50s. So it varies. But I think that's an important score for us to measure ourselves, and we are seeing continuous improvement in that area. The other place is HEDIS scores. There's a whole series of HEDIS scores that we're looking at every year, and I think the good news is, Washington's a little behind the rest of the country, and I think it's just sort of how we roll. There's certain things that we don't do, like we don't require kids to have a physical before they go to school and things along those lines. However, we see the HEDIS scores increasing every year. It's on a track up every year in Washington. So that's definitely another place we look at. We also look at what we're paying out to providers and how that partnership is working, the quality of that partnership, and the cost as well. So those would be the three main areas that we spend our time on.
You got anything to add to that?
I'll just jump in, not to repeat, but all the quality and financial metrics you would expect are things we track for all of our initiatives. We use customer satisfaction. We're pretty old school in that, but it's a very stable metric that allows us to see trend in how we're interacting with our customers. Something we do that's fairly unique in our Premera Listens program, which is our brand, is we're measuring not just interactions with us as a payer through customer service, but we're also polling our members on what their provider interaction was like and sharing those insights back with providers, because we want to deliver a differentiated payer experience, but something that makes a customer for us even more sticky and more willing to stick with Premera is if we can actually improve that experience of care. That's the one that actually matters at the end of the day. And so that's something that's unique. I would say the other thing is we're tracking a whole new set of metrics now that we have a primary care station. Now we start caring about things like wait times. We start caring about things directly related to that patient-provider experience in a way that we have just not done before. It's far more visceral, but I think it's going to awaken us to the experience across the board, not just in facilities we happen to manage or participate in directly, but in those across the spectrum, whether they're closely partnered or otherwise. So I'm excited about this new advent of direct experience metrics that we're entering into now.
Laurel?
I think the only thing that maybe I would add that we didn't touch on is one of the things at Molina that we do that's maybe a very personal way of measuring is we actually start every single one of our management meetings, what we call it a member reflection, and we track what's going on with our members, especially those in our care management programs, to understand kind of what the challenges they were facing, how we interacted with them, and what have been the outcomes. So it's been really a really powerful piece of how we ground ourselves and making sure that we keep our members and our patients at the center of how we evaluate our work.
So I'm going to roll up a couple of our last two questions into one, if we can do so. So thinking about impactful innovations that have either been adopted, you would like to adopt, or that haven't even been created yet, what are the impactful innovations that you would like to see emerge if they don't already exist? If they do exist, how did you adopt them? And if they don't exist, how can we help you find those innovations? How can we support you as entrepreneurs and as a community develop those innovations, given that it might be 2 years out, 3 years out? Laurel, would you like to start?
Yes.
Okay, sure. So I think for us at Molina, probably the key area where we would have a pain point really is in finding and engaging with our individuals, with the folks, and even with finding and engaging members at a population level. And I think one of the panels earlier we were talking about a whole lot of opportunities where there's so much that maybe folks don't even really can't get engaged. So, so for our perspective, I think one of the ways that we're wanting to get involved is Molina actually launched a community innovation fund in 2019, and we're wanting to identify kind of at the community level areas where we can improve that engagement and improve community and clinical linkages. So that really is a focus for us.
Christy?
Yeah, so one of the areas that we are doing right now that is an innovation I'm excited about is a program that we call Common Care. And we're actually working on renaming it because I think that the name is a little bit of a misnomer. The idea of it is that we have a common care plan with our providers. And actually, that's a very uncommon thing. What we found, especially as more providers are moving into value-based care, a lot of providers are developing care management programs, which I think is fabulous. And I think providers have a much better opportunity of really engaging the member, the patient, than a lot of times the health plan does. And we want to empower the providers to do that. In a lot of cases, we still hold the financial risk, and we have a lot of data and insights. So what we've done is developed this program where we're, instead of the health plan reaching out to a member and engaging them in care management, and the provider doing the same, and either creating confusion for the end patient, or worst case, making the assumption that the other's doing it and we miss somebody, we're working collaboratively on this, where we have insight, where we can go for a lot of these partners directly into their EMR to see, learn more about the clinical conditions, sending our own insights over to provide a 360-degree view of who's been in the emergency room, in the hospital, what medications are being filled, and really having that be we're coming together and each bringing our own capabilities to better serve the member, the patient. And we're hearing great results from our patients saying, finally, my health plan and my provider are working together on my behalf.
A few things. Given all the data we sit in, we can better predict than ever before who's going to be costly next year, who isn't today. All of us, probably being average healthcare consumers today, probably don't think of ourselves as being a great risk. But there's things about you that the broader ecosystem understand that make you higher risk in the future. The thing about it is none of us want to be engaged by our payer in that discussion, at least probably at the outset. So the next round of innovation there, and we're working with a partner called Prealize, formerly Cardinal Analytics on this, that's doing great work in the space, is now that we have an algorithm, now that we've applied some machine learning to healthcare claims data in particular, now what do we do with it as a matter of use case to engage members and change their trajectory? The second area I would briefly reference is a huge deficit that still exists. It's one I alluded to before, and I brought up 2 years ago when I sat up here in a similar setting. The gap that exists around trust is what creates friction for customers and for all of us in this room when we engage the healthcare ecosystem. A little trust would allow us to do things like automate prior authorization. There is no reason we're expending all the human capital we are today among our respective organizations to review things that can be done in an automated fashion. That takes technology and apps, absolutely, but more than that, it takes trust, and that's what I'm after.
So Doug, would you like to sort of close this one out for us?
Sure. There's a few things. I already talked about trying to put together as much information in the patient's hands as possible, which would include their electronic medical record. We've already got Epic here in Washington, and almost all the providers are on Epic. Behavioral health providers are not. But I would love to see, as much as we can, that information added. But also the claims information that goes along with that, and the community information. There's lots of community information that could be added. Imagine if you were a provider and you could see, does this person have transportation? Do they have food? Do they have are they justice involved? Do they have housing? Are they part of the housing authority? So we're doing exchanges of data with the housing authorities here. You know, out of our 200,000+ members, we've got 14,000 members.
See,
Innovation.
It's done. Problem solved.
If only healthcare were that convenient.
It's already working. Right. Anyway, so we're doing data exchanges with the housing authority and looking at hotspots and looking at how we can intervene there. And just practical solutions. One of the things that the Medicaid groups all got together, the payers got together, and we are funding respite care. So those patients that are in the hospital that really can't go back into the street, but they need to be in somewhere where they're getting intravenous meds or something along those lines, can go to that respite care at much less cost and much more practical. So, you know, those are just 3 things, but I could probably talk about this much longer. I think we're out of time for that.
We have moved to the audience Q&A. So, I would also suggest, before we start the questions, that if you would like to talk to the panel here, it's quite difficult to get access to payers, to people that understand the systems, to understand how the data move around the system. So I really, beyond the questions and answers, if you can talk to these folks and some of the other payer representatives in the room, this is a unique piece of the group. So please take advantage of it.
So,
Right, so we're going to start with a question. We've got a gentleman with the mic at the back.
so thank you all for coming in and talking, and really excited to hear what you're saying about value-based care. I think a lot of the innovations and technology that everybody in this room works on can really be realized under value-based care. However, with things like the recent admission from Humana that only 10% of the dollars on their value-based contracts are actually value-based, it seems like fee-for-service is still the elephant in the room. I was curious how you see digital health and innovation operating in a fee-for-service world as we transition to value-based care.
Well, you know, there really is a definition of value-based that you know, falls on a continuum. So, you know, one end of that continuum is paying for quality. So, you know, paying bonuses and adding payment to that provider around the quality piece. And the other end of that spectrum is full risk, where you're pushing everything to the provider and they're taking full risk, upside, downside. So we're all somewhere in between. But as I said earlier, I don't know about Humana, but we're really at 90%. So 90% of our dollars going out are into a contract with a value-based provider. So, you know, Medicaid's been pushed a little bit differently. I mean, the dollars are incredibly tight. You know, we're probably paying 35, 40 cents on the dollar compared to commercial. So, you know, it's really out of necessity, I think, that we've been pushed in a different direction.
Got one other person that might like to add to that? Christy, Laurel, Nathan?
Sure,
Tough
I can
question.
jump in. I think digital health is following the rest of the healthcare system, which is still predominantly fee-for-service. Washington's made great strides, but I think the economics providers look at, no matter what your value-based contract says, is what the end game is, what those widgets ultimately add up to, with or without the value component. And I don't say that to sound skeptical, but just hopefully realistic. I think getting on the same side of the table, payers and providers doing so for the customer, actually requires something much deeper, much more behavioral, and I would go so far as to say, until you really share a P&L around a defined population, it's virtually impossible to align the incentives to really see change happen on a care delivery basis.
Okay, got a
Hi, yes, thank
colleague
you
at the
for your
back.
time today. Last year I had the opportunity to actually travel internationally and see what's actually going on in the rest of the world as it relates to digital health adoption. So thanks, David, for that question. And it made me wonder and think that, is digital health adoption going to follow the way mobile technologies were adopted, where it all happened outside of the US first, and then the US was almost the last geography to adopt? And I say that because within the payer and policy changes that you're seeing, it seems like there's a lot more work and activity being done on the payer side to promote the adoption of these technologies through the providers. So I would just love the panel's perspective on 2 questions. One, do you think we're going to get lapped by the rest of the world? And what do you think the role of digital health is right now?
Who would like to start with that one? This again.
Well, I will
that.
answer. I will answer for United, and we are spending. I would say I can't even gather the amount, but we are spending a ton of money on digital, looking at innovations via digital. There are partnerships forming all over the country, literally thousands and thousands of small companies looking at digital. And we're constantly looking for companies we can work with or acquire that will add to our digital capabilities. So I don't, you know, I think, you know, the United States is, if anything, innovative. And I don't know that it would come from outside our country. I think that we have great opportunity here.
Yeah, we're also making huge investments in the digital space. And a lot of the technology, it takes a while to gain adoption. And I hearken back to the panel that we heard from this morning, our patient panel, and we heard them talk about the importance of having a relationship, wanting to be understood on a personal level. And I think it's going to have to be a both and, that we're creating access to both a delivery system that can create that personal relationship, as well as having options for how do I connect on a digital platform in my busy life. And I think that we can't solve for one without the other.
I kind of suspect the next generation may want less of that, more digital.
I think that's right. And
I'm
I think
only
you can't
basing it on my trips in the elevator. I live in town here with
Everyone's
all
down.
the Amazon folks, and you know, no one talks to you. They're all on their phones. So
Yeah.
I just think digital is gonna
I
be
think we
very
have to
different for
solve-
the next generation.
I think we have to solve for both. I definitely think we'll see much more adoption over time.
Yeah.
And we have to be able to have both, you know, those in-person solutions as well as digital solutions.
Yeah. Agree.
We got one more. I think we've got Suzanne at the front here. Oh, all right, never mind.
Nick Postiglione with UW Medicine. So I have a quick question for you. I know we're about out of time, but how do you partner with health systems around innovation in this space? What I often see with a lot of our patients in the call center, a lot of times they say, go talk to your health insurance company about that question. And then they say, my health insurance company told me to talk to you. So how do you work with health systems on improving the gaps in care or helping patients understand where they need to go and who they need to talk to?
We're trying a few things, including with UW. And let me start, though, with saying when you align the economies, it creates an avenue for innovation that otherwise is very hard to pull off. So when you have shared accountability, again, beyond contractual, for the customer, you're able to do a lot of cool things. The two examples I'd provide is, one, we have our branded product called Premera Pulse, which chiefly is a scheduling and referral interface, making real-time scheduling available, which is not prolific, for customers to actually schedule slots the way you can do for every other sector except healthcare. And also allows those providers now seeing our patients to refer and steer to the best quality, most affordable providers for that customer, and to do so in real time with limited friction. And we're seeing a tremendous amount of adoption in Washington. We actually started that program in Alaska and saw great returns there. The second thing, when you have the shared economies, you're on the same side of the table fighting for the customer and their needs. You do things like take that insight around who's going to cost bloom next year, like the 2 or 3 of us in the room who are that, and now you have real aligned incentives to figure out a way of addressing that population. The partnership that's exciting for me is I think providers, especially primary care providers, are in a far better position to intervene with cost blooming populations, but we have to serve up those preferences and insights in a way that's meaningful and a way that's connected. So that's the 2 examples I might provide.
Yeah, and I think I would just add to that with the push towards value-based care. We've put a tremendous amount of energy into provider engagement with our value-based provider partners to try and bring that not just data but actual actionable information to help identify, you know, how can we work together, and also to really leverage where our providers already have, say, a telehealth solution or a program that's getting great results on maternity or what have you, to help promote that versus trying to compete.
Excellent. So there is no way that we're going to come close to addressing half of the issues, or even a quarter of the issues, or maybe even a tenth of the issues that the payer stakeholder group essentially have, let alone address the questions that the room has as well. What we are going to have to do, though, is cover the question for the next group, the pay. We are the payers, so it's going to be the purchasers. Thanks. And that question is, what products are purchasers willing to pay for? Simple question, right? Apps, wellness programs, social determinants of health. You know, what are the products that purchasers are willing to pay for? So with that, I think we've got lunch coming up.
We do. Thank you, Chris.
Yep.
Please join me in thanking the panel. Wonderful job, guys. Thank you so much.